Monoclonal gammopathy of undetermined significance is basically identified when most of the time, when you identify a monoclonal protein in the serum. As you can see on this slide, on the left-hand side, you have the normal serum protein electrophoresis. And on the right-hand side, you can see how a monoclonal protein looks like as a discrete band. And on immunoelectrophoresis here, you can see that this particular patient, the monoclonal protein is G lambda. When you see a monoclonal protein, but the patient does not have any features of myeloma, amyloidosis, Waldenstrom's macroglobulinemia, or related disorder, we call that MGUS, or monoclonal gammopathy of undetermined significance. That term was coined by Dr. Kyle in 1978 when he first published The Natural History of Patients with MGUS in 241 cases seen at the Mayo Clinic. Nowadays, to detect monoclonal proteins in many labs, we are using mass spectrometry. Mass spectrometry, you can identify the monoclonal protein very precisely. As you can see here, this is an IgA monoclonal protein with a precise molecular weight. Sticks out very clean. In fact, it's very sensitive. This particular patient, the myeloma was diagnosed in 2007. And in the Mayo Clinic, we had sample going back 10 years. And in 1997, the patient's immunofixation was actually negative, but the mass spec, when you go back and run it, picks up the same monoclonal protein years prior. So it's a very sensitive technique and one of the advances. So what is the epidemiology of MGUS? MGUS, or monoclonal gammopathy of undetermined significance, the prevalence is, the first prevalence estimate was by Dr. Kyle of about 3.2%. This was in this landmark study that was published in the New England Journal of Medicine in 2006. You can see here the prevalence increases with age. It's higher in men than in women. It's 3 to 3.2% of the general population age over 50. When you go over the age of 70, it's more than 5% of the general population. Now, I told you with more sensitive techniques, we think that the prevalence of MGUS is actually higher. When you use serum free light chain assay, the prevalence goes up to 4.4%. And when you use the mass spec plus the free light chain assay, the estimated prevalence is at least 5% of the general population over the age of 50. So very common condition, and we really need to know more about it. As people do more and more tests for monoclonal gammopathy with SPEP or immunofixation or mass spec, you're going to find more and more referrals for MGUS into your clinics. Now, the International Myeloma Working Group has revised the diagnostic criteria. And you can see here for myeloma, we added these 3 biomarkers, more than 60% plasma cells, more than 100 for the light chain ratio, and more than 1 focal lesion for MRI. Basically, those are myeloma defining events. But MGUS, the definition is still the same, less than 10% plasma cells, less than 3 grams M protein, and no myeloma defining events. Based on the type of MGUS, you can, the type of progression will be different, and the risk of progression also will be different. There are basically 3 types of MGUS. One is the non-IgM MGUS, that will be IgG MGUS or IgA MGUS. The risk of progression is about 1% per year, and the type of progression is myeloma or plasmacytoma. On the other hand, IgM MGUS most of the time progresses to Waldenstrom's, not to myeloma, and the risk of progression is slightly higher. Then we have a third type now, which you can detect only by the free light chain assay. That's the light chain MGUS, and that progresses to light chain myeloma, and the risk of progression or the rate of progression is not well known. Now, all of these types of MGUS can progress to amyloidosis, and that must be kept in mind. The prevalence of MGUS is higher in first-degree relatives of people who have myeloma, 2 to 3 times higher. This is the expected prevalence of MGUS, and here you can see the first-degree relatives having a much higher prevalence at every age group. So that's something to keep in mind. It's 2 to 3-fold higher risk of MGUS in first-degree relatives. Similarly, Black people, African Americans, as well as in our studies in Ghana, we find have a higher risk of MGUS, and that's why they have a higher risk of myeloma. I don't think there is an increased risk of transformation of MGUS to myeloma in African Americans and in Black people, but there is definitely a higher risk of MGUS. And if you look at the people age 40 to 49, you can see already the risk of MGUS is only 0.53% in whites compared to 3.26% in Black people. So I think one of the reasons why myeloma is higher in Black people might be the higher prevalence of MGUS and the earlier age of onset of MGUS. We can risk stratify MGUS. MGUS has a risk of progression of 1% per year. You can see here that over time, if you follow patients with MGUS, there is a risk of progression of 1% per year. So if you follow them for 20 years, there'll be a 20% risk of progression. But you can fine tune that risk by just looking at the M spike size, the type, and the free light chain ratio. If patients have a very small MGUS, that is IgG, and the light chain ratio is normal, then the risk of progression is quite low. On the other hand, a non-IgG MGUS with the abnormal light chain ratio and a fairly big M spike of more than 1.5 grams, that would have a higher risk of progression. And if you look at competing causes of death, after all, patients with MGUS can have other diseases, other cancers as well. So the true risk of progression competes with other causes of death. And if you look at low risk MGUS, the actual chance that somebody with low risk MGUS will get myeloma or related disorder is only 2% over their lifetime. So it's not even 1% per year, it's much, much lower. So in these patients, if you want to follow them every year and do a bone marrow biopsy, bone survey, it's just way too much and it's completely unnecessary. So here is how we incorporate this risk stratification into our management. Patients with suspected MGUS, if they have a low risk MGUS, less than 1.5 grams, these are the most common referrals we get. Small MGUS, IgG type, normal light chain ratio. Or if it's an IgM MGUS, where there is really low risk of renal failure or lytic bone lesions. Or a light chain MGUS, where the free light chain ratio is abnormal, but only slightly, and the ratio is less than 8. If there's nothing really worrisome, uncomplicated, nothing to worry, everything looks okay. Somebody just ordered a free light chain assay or an SPEP and they found this finding. There you can defer the bone marrow biopsy at baseline and defer the skeletal survey, because if you did this, you will find an MGUS. You will find less than 10% plasma cells and the skeletal survey will be normal. How do we know that? The Italians have done this study and that's what they find. And in these patients, you can just defer it. 6 months later, you can recheck, and if there's anything, we can worry at that time. All other patients, though, or if you have any concerns, go ahead and do the bone marrow biopsy, go ahead and do the skeletal survey, and then you will get your final risk stratification. How do you follow them? All patients with MGUS, whether they are low risk, high risk, you recheck in 6 months. If it's stable, for these patients whom I said are low risk, you don't need to do any more annual follow-up, just usual medical care. And if they have symptoms suggestive of myeloma, at that time you can reevaluate them. All other patients, though, you would have to follow once a year with CBC, calcium, creatinine, protein electrophoresis, and free light chain assay. When you follow them in 6 months, anybody with MGUS, if there's worry for progression, then you have to really do a full-blown workup with another bone marrow, bone survey, and manage accordingly if you find something. Important to keep in mind that if you take 1,000 patients with MGUS, only 10% will progress to myeloma-related disorder. Most of them will have death due to other causes besides myeloma, like breast cancer, lung cancer, cardiac disease. So that's what's going to get them 90% of the time. So you should never forget all of the other management things that you have to do for your patients: colonoscopy, prostate cancer screening. For MGUS patients, myeloma is not the main problem or the only problem that you need to worry about. You have to look at all these other things as well: high blood pressure, diabetes, everything. Now, if MGUS only caused myeloma as a problem, that's one thing, but MGUS can cause Waldenstrom's, as we talked about. MGUS can cause amyloidosis, but importantly, MGUS can also be associated with all sorts of other disorders. In this case here, it's a cryoglobulinemia. So besides these known things and amyloidosis, cryoglobulinemia, light chain deposition disease, these are all problems that are caused not by the plasma cell, but by the monoclonal protein, which is a functioning antibody in some patients. So it can cause a glomerulonephritis, it can cause skin disorder, it can cause arthritis, it can cause autoimmune disorders, it can cause neuropathy. So all of these problems have to also be considered. This is what they sometimes call monoclonal gammopathy of clinical significance or monoclonal gammopathy of renal significance and so on. But you have to really make sure that it's really caused by the monoclonal protein and not by something else. And so you have to rule out all the other causes. Finally, a last word about screening. Generally, we do not recommend screening for monoclonal gammopathies because there's nothing we can do. Plus, screening has not been validated. A randomized trial, the iStop-MM, is going on in Iceland, and that will answer the role of screening. However, there are some selected populations for whom screening might be still considered. These are ultra high risk patients where I think we should consider screening, and that is Black people who already have one affected first degree relative with myeloma, or people who have already two first degree relatives with myeloma at the age of 50 or higher. You might want to consider screening.